Hello everyone and welcome to our module on electrolytes. Let's start by talking about potassium. In other videos, I talk about how the heart and the skeletal muscles have action potentials that depend on potassium. If you know this, then it's easy to remember that the major effects of hypokalemia or hyperkalemia include things like EKG changes, arrhythmias, and weakness. These are all effects on the heart and the skeletal muscles. We'll talk about hyperkalemia first. This refers to a rise in the serum potassium level. When the serum potassium level gets high, you can see a number of arrhythmias. In particular, there's often arrest of the sinus node. That's what's shown in this tracing at the bottom of the screen. You can see there are just no P waves for a long period of time. That's because the sinus node has shut down in the setting of hyperkalemia. You can also see various forms of AV block. In terms of the muscles, when the potassium gets high, muscles become weak, and if this is severe, it can progress to paralysis. Classically, it begins in the lower extremities first. They have very large muscles, and that progresses to the trunk and then finally the upper extremities. And then there are a couple of classic EKG changes you should be aware of. The first one is peak T waves, and the second is QRS widening. This is an example of peak T waves on the screen. So these T waves are much taller than what is normally seen, and a lot of people remember this by just thinking that potassium hides under the T waves. That's also a way to remember that the T waves get flat in the setting of hypokalemia, which we'll talk about later. The EKG at the top of the screen shows QRS widening. This is a patient who developed acute renal failure and had a potassium level of 9. A normal level is 5 or less. You can see that these QRS complexes are just enormous compared to normal QRS complexes, which I've showed at the bottom of the screen for comparison. If you ever see very, very wide QRS complexes like this, it's almost always due to hyperkalemia. Let's talk about the causes of hyperkalemia. Far and away, the most common cause of hyperkalemia you will see clinically is acute or chronic kidney disease. You need your kidneys to excrete potassium, and when the kidneys get sick, there's decreased potassium excretion in the urine. And this is a cross-section of a kidney here on the screen just to remind you of this. You also need aldosterone to secrete potassium. Remember that aldosterone triggers renal secretion of potassium. So in patients with a type 4 renal tubular acidosis, they have aldosterone resistance, and these patients also develop hyperkalemia. And I talk about this in the video on RTAs. Other causes of hyperkalemia are shown on this slide, and all of these causes relate to increased potassium release from cells. Cells in our body have a very high concentration of potassium, and if these cells begin to release potassium, you can see an overall rise in the serum potassium level. The first cause is acidosis, and this has to do with potassium and acid exchange. Cells in our body have pumps which can exchange hydrogen ions for potassium ions. In the setting of acidosis, there's a very high concentration of hydrogen ions, so these pumps become more active. They bring those hydrogen ions into the cell and they pump out potassium ions, and this can raise the overall serum potassium level. The next three causes, insulin deficiency, beta blockers, and digoxin, all relate to the sodium-potassium ATPase pump found in our cells. Cells in our body have a sodium-potassium ATPase pump that can bring potassium into the cells in exchange for sodium. This pump is activated by insulin, and it's also activated by epinephrine. This means that if you are insulin deficient, or if you are on a beta blocker that blocks the effects of epinephrine, you will see the potassium level rise because this pump will become less active. In addition, this pump is blocked by the drug digoxin, so for the same reason, hyperkalemia can occur in patients taking digoxin. Any process that causes cells to lyse, such as tumor lysis syndrome that occurs when high dosages of chemotherapy are administered, this can lead to hyperkalemia. And then finally, if the serum osmolarity is very high, this will draw water out of cells, and that water will carry potassium with it, and that can potentially cause hyperkalemia. Now let's talk about hypokalemia. Hypokalemia can also cause arrhythmias. There are many arrhythmias reported in the setting of hypokalemia. Some of the common ones are PACs or PVCs or sinus bradycardia. Just like hyperkalemia, hypokalemia can cause muscle weakness, which can potentially progress to paralysis if the serum potassium level is very low. Also, just like hyperkalemia, the symptoms begin in the lower extremities and progress to the trunk and upper extremities. And then there are a number of potential ECG changes you can see in patients with hypokalemia. The classic ones are U waves and flattened T waves. A U wave is a little bump that comes after the T wave, as shown in this tracing on the screen here. The origin is unclear. One of the theories is that they represent repolarization of the Purkinje fibers, and although U waves are seen in hypokalemia, they can also be a normal finding. And then, as I told you before, T waves get very peaked in hyperkalemia and they get very flat in hypokalemia, and this is an example of flat T waves shown in this tracing on the screen. Most of the patients you will see clinically who have hypokalemia have either increased renal losses or increased GI losses. The classic cause of increased renal losses of potassium is the use of diuretics, especially loop diuretics. Patients on loop diuretics often develop hypokalemia, and they often have to take a potassium supplement along with their diuretic medication. And also patients with type 1 and type 2 RTAs can develop hypokalemia, and I talk about this in the RTA video. And then your GI secretions have lots of potassium in them, so patients who have vomiting or diarrhea will often become hypokalemic. You can also develop hypokalemia from increased potassium entry into cells. Basically, this is the opposite of what we talked about before. So earlier, I told you that insulin deficiency can cause hyperkalemia. Well, a hyperinsulinemic state can cause hypokalemia. And in fact, one of the treatments for life-threatening hyperkalemia is to administer insulin. That will drive down the serum potassium level. The reason insulin works to save someone's life in the setting of hyperkalemia is because it will activate the sodium-potassium ATPase and drive potassium into cells. In addition, we talked earlier about how beta blockers can cause hyperkalemia. Beta agonists can cause hypokalemia. So drugs like albuterol, terbutaline, or dobutamine, which activate beta receptors, can drive potassium into cells. And then finally, earlier we talked about how acidosis was associated with hyperkalemia and alkalosis is associated with hypokalemia. And then finally, a low magnesium level or hypomagnesemia is a famous cause of hypokalemia. I'll discuss this in more detail later in this video when we get to magnesium, but hypomagnesemia promotes urinary potassium loss. And importantly, you will not be able to replete the patient's potassium until you correct the mag first. The classic scenario is a patient with hypokalemia who does not respond to potassium therapy. That patient likely has a low magnesium level, and you have to fix the magnesium first. Moving on, let's talk about calcium, and we'll start by talking about the symptoms of hypercalcemia. You should be aware that in the modern era, most patients diagnosed with hypercalcemia are asymptomatic. The elevated calcium level is identified as part of blood work done for another reason. Another common presenting scenario is recurrent kidney stones. Many kidney stones contain calcium, so patients who have multiple kidney stones are often tested for hypercalcemia. You should also know that patients who develop an acute increase in the serum calcium will have polyuria. Calcium induces a form of nephrogenic diabetes insipidus where the kidneys cannot concentrate the urine. This is believed to occur because of downregulation of aquaporin channels. The result is excessive free water excretion and a fall in the GFR and acute renal failure. If you ever meet a patient with an acute increase in calcium, this is usually from malignancy, they will be extremely dehydrated and thirsty, and that's because of these effects of calcium on the kidneys. If patients have long-standing untreated hypercalcemia, they will develop the findings shown in this slide. This really doesn't happen in the modern era. This used to happen 100 years ago when there was no way to diagnose hypercalcemia. So at that time, the classic symptoms were remembered by the mnemonic stones, bones, groans, and psychiatric overtones. The stones were the effects on the kidneys like polyuria and kidney stones and renal failure, as I explained on the last slide. The bones were bone pain. This results from increased absorption of calcium from bones. The groans were abdominal pain. That's because hypercalcemia can cause constipation, anorexia, and nausea. And the psychiatric overtones were anxiety and altered mental status. The two most common causes of hypercalcemia that you'll see clinically are hyperparathyroidism and malignancy. In the endocrine video on the parathyroid gland, I talk about how high levels of PTH lead to hypercalcemia. In addition, many malignancies promote the breakdown of bone, and this also leads to hypercalcemia. Two other causes of hypercalcemia that you should know for step 1 of your boards are shown on this slide. Hypervitaminosis D occurs when there are excess levels of the active form of vitamin D found in the body. This has been rarely reported among patients who consume massive amounts of the active form of vitamin D calcitriol via supplements. This can also occur in sarcoidosis. That's because granulomas have macrophages with the 1-alpha hydroxylase enzyme which activates vitamin D. So this can go on to lead to elevated activity of vitamin D. And then the milk alkali syndrome is a largely historical cause of hypercalcemia when years ago patients would drink milk and take sodium bicarbonate to treat their peptic ulcers. This can also be seen sometimes among patients taking high levels of calcium carbonate to treat ulcers. What happens in this scenario is that patients are consuming lots of calcium and also lots of alkali. That's why it's called the milk alkali syndrome. The high calcium consumption causes hypercalcemia. That leads to renal failure, as I told you before. before, and the high alkali intake causes a metabolic alkalosis. Next, let's talk about hypocalcemia. The classic sign of hypocalcemia is tetany, which means muscle twitches. If you ever meet a patient with hypocalcemia, what they will complain of is that their muscles are twitching. Usually it's the small muscles of the face, like their cheeks or their eyelids. The reason this happens is because under normal circumstances, calcium exerts a mild blocking effect on sodium channels in neurons. Therefore, when you have a low calcium level, it's very easy for neurons to depolarize, and this leads to spontaneous contractions of muscles. It can occur anywhere, but it often occurs in the small muscles of the face. And just to go back to hypercalcemia, when you have high calcium, this leads to difficult depolarization of neurons by this same mechanism right here, and that's why you get weakness in hypercalcemia. So in the setting of hypocalcemia, what you have is hyperexcitability of neurons and motor end plates, and that leads to muscle twitching or tetany. There are two classic signs of tetany. They're mostly historical. The first one is called Trousseau's sign. This is hand spasm when you inflate the blood pressure cuff on a patient's arm. The second sign is called Schwastik's sign. This is facial contraction when you tap on the facial nerve. Both of these are signs of tetany. And then in addition to tetany, the other classic sign of hypocalcemia is seizures. I've listed some causes of hypocalcemia on this slide. Hypoparathyroidism causes hypocalcemia, just like hyperparathyroidism causes hypercalcemia. Patients with renal failure have decreased activation of vitamin D, and this leads to low calcium levels. In patients with pancreatitis, there can be saponification of magnesium and calcium in necrotic fat. I talk about this in the GI section in the video on pancreatitis. And then finally, there are some drugs like foscarnet which can lower the calcium level, and I'll talk about this at the end of this video. And lastly, magnesium has effects not only on potassium, like I mentioned before, but also on calcium. And you can see hypocalcemia in the setting of low or high magnesium levels. And I'll talk about this more later in this video when we get to magnesium. Phosphate disorders are very rare, but I'll go through them now. Hyperphosphatemia involves elevated levels of serum phosphate. The classic cause of this problem is acute or chronic kidney disease, which I'll talk about on the next slide. You can also see elevated phosphate levels in hypoparathyroidism. And finally, you can see at any time there is a huge phosphate load. So in the tumor lysis syndrome, lots of phosphate spills out of cells. This raises the serum phosphate level. The same thing happens in rhabdomyolysis when muscle cells die. You can also rarely see this in patients who consume large amounts of phosphate-containing laxatives like Fleet's phosphosoda. Patients who have renal failure classically develop hyperphosphatemia and hypocalcemia. The reason this happens is because when the kidneys are sick, they cannot excrete phosphate, and that raises the serum phosphate levels. In addition, sick kidneys cannot activate vitamin D, so you have a fall in the active form of vitamin D, 125-OH vitamin D. This leads to less calcium from the gut, and that contributes to hypocalcemia. In addition, the elevated phosphate pulls calcium out of the plasma, and this also leads to hypocalcemia. In turn, the low calcium increases the parathyroid level, and therefore parathyroid hormone levels are usually increased in patients with renal failure. Here's a slide from our video on nephron physiology. In that video, I talk about how cells in the proximal tubule have a co-transporter for sodium and phosphate, and this co-transporter is inhibited by parathyroid hormone, and that leads to increased phosphate excretion. So if you have low parathyroid hormone levels, this transporter will be more active, you will reabsorb more phosphate, and you will develop hyperphosphatemia in the setting of hypoparathyroidism. The opposite happens in the setting of hyperparathyroidism. Most patients who have hyperphosphatemia are asymptomatic. When signs and symptoms occur, it's usually from hypocalcemia, and that's because phosphate precipitates serum calcium, just like I told you before in the setting of renal failure. So anytime you see a patient with hypocalcemia, one of the potential causes may be that their phosphate level is elevated. And if their phosphate level is elevated, in other words, if you have a high phosphate level and a low calcium level, what you should first think of is renal failure. This is the classic combination seen in renal failure. Patients with renal failure who have high serum phosphate levels often take drugs called phosphate binders. These will lower the serum phosphate level back towards the normal range. One of the reasons they do this is because long-standing untreated hyperphosphatemia can lead to a problem with the blood vessels diffusely throughout the body. This is called metastatic calcifications. It's also sometimes called calciphylaxis. This is only seen in chronic hyperphosphatemia among patients with chronic kidney disease. What happens is the high phosphate levels lead to phosphate being taken up by vascular smooth muscle, and then the blood vessels basically undergo a process of osteogenesis where they become more like bones. As a result, the vascular walls become calcified. This can lead to increased systolic blood pressure because there's less vascular compliance. It can also lead to thrombosis of small blood vessels, and this can lead to painful nodules and skin necrosis. And this is a picture on the screen of someone with calciphylaxis and necrosis of the skin from this process. Just like hyperphosphatemia is rare, hypophosphatemia is also a relatively uncommon disorder. When it does occur, the main acute symptom is weakness. You need phosphate to make ATP, so when you have hypophosphatemia, your ATP levels become diffusely depleted, and this will present as muscle weakness. Often it's respiratory muscle weakness, so in a patient who is in the right clinical scenario for low phosphate levels, if that patient develops respiratory difficulty, one thing you need to consider is that they may have low phosphate levels. Chronic hypophosphatemia over time leads to bone loss and osteomalacia. This is usually not seen in the modern era. I've listed some select causes of hypophosphatemia on the slide. First of all, primary hyperparathyroidism reduces phosphate levels. The next two causes I've bolded because they're very high yield for you to remember. Diabetic ketoacidosis, or DKA, classically leads to hypophosphatemia. That's because glucose induces a diuresis and you lose phosphate in the urine. In addition, alcoholics who have poor nutrition and are admitted to the hospital can develop what's known as the refeeding syndrome. So alcoholics have chronically low phosphate levels from poor nutrition, and when they start to eat food, their metabolism ramps up and this further decreases the phosphate level. So in either an alcoholic or a person with DKA, if you see a description of hypoventilation and respiratory muscle weakness, one thing you should think of is that there may be a low phosphate level. Hypophosphatemia has also been reported among patients taking certain antacids that bind phosphate. The classic one to do this is ammonium hydroxide. And then patients who have the Fanconi syndrome have wasting of phosphate in the urine, and this can lead to hypophosphatemia. I'll finish this video by talking about magnesium. This is the most confusing electrolyte, and the reason is because magnesium levels can alter the levels of calcium and potassium. For this reason, magnesium disorders often go together with disorders of other electrolytes. We'll start by talking about hypermagnesemia. To understand the signs and symptoms of increased magnesium levels, you need to appreciate that magnesium can block calcium and potassium channels. For this reason, many of the effects of a high magnesium level are similar to the effects of low levels of calcium or potassium. So for example, patients with hypermagnesemia often have neuromuscular toxicity. This presents as decreased reflexes and weakness that can progress to paralysis. They also have cardiac dysfunction. Things like bradycardia and hypotension and even cardiac arrest can occur. And then finally, hypermagnesemia can cause hypocalcemia, and this is because magnesium can inhibit parathyroid release. In the video in the endocrine section on the parathyroid gland, I talk about how high levels of magnesium can shut down parathyroid hormone release, and this can lead to hypocalcemia. There's really only one important cause of hypermagnesemia, that's renal insufficiency. When your kidneys don't work, you can't excrete magnesium, and this can lead to hypermagnesemia. Patients with hypomagnesemia also have neuromuscular problems, but in this case it's excitability, very similar to what we described before with low calcium levels. Patients with low magnesium levels can have tetany and also tremor. They can also have a number of cardiac arrhythmias. But the two very high yield effects of hypomagnesemia that you always want to remember for board exams are hypocalcemia and hypokalemia. So let's talk about how low magnesium leads to these two problems now. The effect of a low magnesium level on the parathyroid gland depends on whether the level is a little bit low or very low. If there is a slight reduction in the serum magnesium level, this can stimulate parathyroid hormone release, just like hypocalcemia does. The reason this happens is because parathyroid hormone, in addition to raising calcium levels, can increase GI and renal magnesium reabsorption to raise magnesium levels. So basically, a small reduction in the mag level leads to more PTH release to bring the magnesium level back up to normal. If, however, you have a severe case of hypomagnesemia, this will inhibit parathyroid hormone release. This is the opposite effect of low magnesium. The reason this occurs is because some magnesium is required for normal functioning of the calcium receptor in the parathyroid gland. I talk about this in more detail in the endocrine video on the parathyroid gland. When this happens, there's abnormal function of this calcium receptor, and that leads to suppression of parathyroid hormone release. So for this reason, hypocalcemia is often seen in severe cases of hypomagnesemia, and it is very high yield to remember this. Patients with hypomagnesemia also classically develop hypokalemia. And the reason for this is because magnesium inhibits potassium excretion under normal circumstances. In the kidney, there is a potassium channel called ROMK. This stands for the renal outer medullary potassium channel, and it's found in the cortical collecting duct. So let's look at the bottom of the screen. Here's a cell in the cortical collecting duct, and here's this ROMK channel, which can allow potassium to go out in the urine. However, this channel is inhibited by magnesium. When you develop hypomagnesemia, this channel basically goes nuts and starts releasing lots of potassium into the urine. For that reason, patients with hypomagnesemia develop hypokalemia. And in addition, you cannot correct the potassium until the mag is corrected, because you need to correct the mag to shut down this channel. So a classic clinical scenario is a patient with hypokalemia and the potassium is being repleted for several days but will not normalize. That patient probably has hypomagnesemia, and you have to fix the magnesium level before you can correct the potassium level. Some selected causes of hypomagnesemia are shown on this slide. GI secretions contain magnesium, so patients with diarrhea can develop hypomagnesemia. Pancreatitis can lead to a number of electrolyte abnormalities. Treating patients with pancreatitis involves close monitoring of the electrolytes. One of the reasons for this is that in pancreatitis there's a process called saponification that occurs, where magnesium and calcium collect in necrotic fat. There are a number of ways you can lose magnesium in the urine through the kidneys. Loop and thiazide diuretics can cause hypomagnesemia, and alcohol abuse is an interesting cause of hypomagnesemia. Alcohol has been shown to cause tubular dysfunction in the kidneys and lead to hypomagnesemia, and alcoholics who present to emergency rooms classically have hypomagnesemia, and that's worth remembering for your boards. And then there are a number of drugs which can cause hypomagnesemia. One of the famous ones is omeprazole, which is a proton pump inhibitor. It's been associated with impaired absorption of magnesium from the GI tract. And another one is Foscarnet, which is an antiviral drug. So let's talk about this now. In the infectious disease section in the video on antiviral drugs, I talk about Foscarnet. It's an antiviral pyrophosphate analog. This is its structure down here on the screen. It looks a lot like phosphate, and it works by binding and inhibiting viral DNA polymerase, and it's used in treating a number of viral infections, including CMV. Some of its side effects include nephrotoxicity. This is the limiting side effect, and also seizures. But in addition, you should know that this drug is famous for causing every electrolyte abnormality you can think of. All of these abnormalities I've shown on the screen have been described in patients on Foscarnet. You're never going to remember all these, but if you see a description of a patient with a number of electrolyte abnormalities, and this drug is one of the answer choices, you should think that that may be the correct answer. And that concludes our video on electrolytes.